those guidelines are showing. So I'm going to go ahead and start sharing my screen. I have two screens here, so let me know if you're not able to see my slides. Give me 1 second. Are you seeing the slides appropriately, or are you seeing my note pages?
We're seeing your note pages.
Okay. How about now?
Perfect.
Okay, awesome, perfect. I always forget which screen it's supposed to be on. I think you guys know who I am. Just relevant disclosures before I get started. I have sat on the Gilead Advisory Board a couple of times, and then I am part of the Pharmaceutical Speakers Bureau, but none of these things should influence our talk for today. In terms of just going through gonorrhea and chlamydia, like we learn in medical school, what the bacteria looks like in terms of Neisseria and chlamydia, you can see here our gram negatives. And also just to review quickly our routes of transmission, as this is important as we talk about screening for our patients. But remember, our route of transmission can be any of these, whether it's vaginal, anal, or oral. And so we'll talk about checking different sites for these infections. The last site also being, remember, can also infect the eyes, so conjunctivitis. And then symptoms depending on the location where the infection is. And oftentimes we will ask about discharge. Having said that, remember that patients can also be asymptomatic, and I find a lot of times we're doing routine screenings because we will check for gonorrhea, chlamydia, and syphilis annually, looking for sexually transmitted infections, at least on an annual basis. And sometimes we're checking a little more often for patients that are at high risk. And many times we have these come up positive and patients have had no symptoms. Remember also onset of symptoms 2 to 10 days roughly with gonorrhea, can be 1 to 3 weeks with chlamydia, but like I said, can also be asymptomatic. And why do we treat these infections? Yes, they can be transmitted from partner to partner, particularly with intercourse, whether that's vaginal or anal, and then also oral. So the complications that we look at of why we're looking to treat is some of these is listed here. And for women, that can even lead to infertility, ectopic pregnancies, when we see things like PID. And then for men, we can see things like epididymitis, particularly when we see something like that, or a proctitis, particularly in a younger individual. Then we want to make sure that we're treating to include the treatment of gonorrhea and chlamydia, as that could be our source. Also, if these things go untreated, can lead to, and we've certainly seen this in our clinic, a lymphogranuloma venereum. So traditionally, this was more seen in third world countries, but really we see that here, particularly in our MSM population, or men who have sex with men, and particularly if we're having anal intercourse, we actually can see, also termed LGV. And so oftentimes the role player in this can be a chlamydia or a chlamydia proctitis. I've even seen a rectal mass occurring because of the infection, and then causing those lymph nodes to get inflamed and causing an LGV. And so we'll talk about treatment when we talk about whether it's gonorrhea or chlamydia causing LGV. Some of the sequelae we can see, and the treatment differs a bit in terms of, we do prolong the treatment course. But these infections can also lead to other things, including sepsis and joint infections, arthritis, and even rashes. So also keep those in mind. Most of the time when we're making this diagnosis, it can be off of culture, but we also do the NAT test or the urine test, and that's what we utilize for screening when we're screening our patients annually. Remember, that's only going to be, if it's a urine test, yes, we may pick up in a female the infection, but if a patient is having anal intercourse, we're not going to pick up if we're checking a urine specimen. So we actually need to culture the anus, and so we do anal paps annually on our MSM patients, and one of the things that we're checking for is gonorrhea and chlamydia. And so we'll talk about, when we talk about treatment, how that differs as well. But you can culture really any of the orifices to be able to detect the infection. And then remember, throat culture can also be done. And so really now we talk about 3-site testing, and that oftentimes will include a throat culture. So we're going to be talking next about treatment, and this is where the new guideline set is located, came out at the end of December. And what changed was really the treatment recommendations for gonorrhea. So previously, if you recall, we've treated gonorrhea with ceftriaxone as well as azithromycin. It was a 2-drug treatment. And really the guidelines have changed in that previous dosing of ceftriaxone or Resefin was 250 milligrams IM injection, along with the azithromycin 1 gram, and that was given as a 1 oral dose. So usually we would give it as 2 500 milligram tablets that they would take in the office as they're getting their ceftriaxone injection. Now they have changed the recommendations to actually eliminate the azithromycin and utilizing a higher dose of ceftriaxone, and that changed to 500 milligrams. That is if the patient weighs less than 150 kilograms. You want to remember, if it's greater than the 150 kilograms, you actually need to change that dosing to 1 gram of ceftriaxone. In these situations, if we have already excluded out chlamydia, then it states that we no longer have to cover with azithromycin or even doxycycline, which was our secondary treatment for chlamydia. If we have not ruled out chlamydia, then they recommend adding the doxycycline 100 milligrams for 7 days, in addition to the 500 milligrams of the ceftriaxone, which will cover our gonorrhea. Also, this is the treatment for if we have a epididymitis or a proctitis. We're also going to be utilizing ceftriaxone with the doxycycline. In the past, azithromycin wasn't studied in those situations, so we would have used doxycycline there anyway. In our clinic, when we're doing those anal paps and we find gonorrhea or chlamydia in the rectum, we traditionally use doxycycline along with the ceftriaxone and didn't utilize azithromycin when it was a proctitis. And currently, so would be the 500 of ceftriaxone with the 100 milligrams of doxy for 7 days. However, if we talked about LGV previously, and if we feel like that the proctitis is actually causing an LGV type of situation where they actually have lymph node involvement, or sometimes I've seen patients who have had fistulas related to or rectal mass related to, if there's a little bit more extensive involvement, we really need to call that LGV and treat that for 21 days of doxycycline, not 7. And we've done this in several occasions through our clinic, treating LGV. I had a patient that even had anal fistulas, was seeing a colorectal surgeon, had some surgeries, they couldn't get it to resolve. In a day treatment of doxycycline did resolve the issues because it was actually related to LGV, which was secondary to a chlamydial infection. These things can be treated. It just have to remember to use a prolonged course of the doxycycline. Also, it does state in these guidelines that there's not a need to test for cure unless there are symptoms, but you do want to retest in 3 months. And that's really more not to say that we didn't test or that we didn't cure, but really because of the high rates of reinfection. We will usually also recommend that partners getting treated so that they're not transmitting the infection back and forth, and then no intercourse for 7 to 10 days until 7 to 10 days after treatment. Oftentimes, the one that is recommended test of cure is if it was a pharyngeal infection. So if you have an oral infection, they do recommend retesting within 7 to 14 days. And that was also mentioned in the guidelines this time. I also have included here alternative treatments if there is a cephalosporin allergy. Then it was stated that our gentamicin along with azithromycin would be our alternative regimen. And then also they talked about using an 800 milligram PO one-time dose of cefixime. I'm going to really mispronounce that. An alternative, but oftentimes this is used for expedited partner therapy. So in the guidelines set, I thought it was interesting that they talked about that there's not any legal ramifications for treating partner. If you choose to do that, then the best would be to use the 800 milligram dose and plus or minus the doxycycline depending on if there was chlamydial infection. I'm not sure if through your facilities if you guys do expedited partner therapy. And so I was curious to just hear some feedback at the end about that, if you're doing that or what the partner recommendations are. Oh, I also wanted to mention one more thing, and that is that we're also detecting more Mycoplasma genitalium. And we actually have testing through our lab now that can test for mycoplasma. We do tend to see it more in an MSM population, and you should have a higher index of suspicion if you've been treating someone's gonorrhea and chlamydia and they're still, or suspect that they have that and they're not getting resolution after treatment. There could be the possibility that it's mycoplasma and that there's azithromycin resistance. So it does tend to respond better to macrolides like azithromycin, but there can be resistant strains. And so it could respond better to a fluoroquinolone or doxycycline because of that resistance that's emerging with the macrolides. So oftentimes I will go with a fluoroquinolone like Avalox, and now that we have the ability to test, and we've actually had several cases of mycoplasma show up in our testing that we've treated with Avalox. Also, I just wanted to mention if it's gonococcal conjunctivitis, then ceftriaxone can be utilized, but should be utilized as a gram. IM one-time dose along with the azithromycin 1 gram. That is still what is recommended if it's gonococcal conjunctivitis. So this is just another way of looking at those recommendations. This is a box straight out of that guideline set in the MMWR. So I just wanted to show what that looked like in a little different way if you reference that. And then just talking about the treatment of the others. So the treatment of the others when they're not associated with gonorrhea is still going to be the same. So if you just have chlamydia, you can still treat with the azithromycin a gram for 1 dose, or you can still use the doxycycline 100 milligrams twice a day for 7 days. Remember that we're going to change the length of therapy to 21 days if we're suspicious that it is LGV. Have that as an increased index of suspicion in your MSM patients, particularly if they're having other symptoms and you're worried about a rectal mass, lymphadenopathy, fistulas, anal fistulas, any of those things, then you may want to try actually treating it as LGV. Here's the dosing for if you have the ability at your facilities to test for Mycoplasma genitalium, or if you've tried treating gonorrhea and chlamydia in patients still having symptoms, then the fluoroquinolone is moxifloxacin or Avalox, 400 milligrams for 7 to 14 days. And remember, with any of these sexually transmitted infections, that it's important that the partner or partners are treated as well, and avoiding sexual activity for 7 days after treatment. Have a few more that I thought that we would just go through. I think probably all of us have seen herpes simplex in our clinics, type 1 or type 2, usually delineated by the location of those sores. Oftentimes type 1, oral sores or cold sores, a lot of times patients will refer to, and then HSV2 or genital herpes, which is spread through sexual contact. I've put the treatment and the doses here on this slide. As on the next slide, I also have the treatment, the prophylaxis doses, which differ slightly. But if you're having a active outbreak, these are going to be our treatment doses. Most of the time through our clinic, we're using the Valtrex or acyclovir, and truthfully, I tend to use Valtrex more if we can get that covered, just because of the ease of administration for treatment twice a day. For prophylaxis, it's half the dose, so Valtrex would be 500 twice a day, or oftentimes patients taking it at 1 gram daily, so we can change it to a daily dosing, which does seem to increase compliance with it. And then here's the length of therapy that I have at the bottom in terms of duration. In some cases, we've seen fairly severe that may require IV therapy, and I've put that there, the IV therapy recommended until you're not seeing any new lesions and those start to regress, and then transitioning over to oral therapy. And these are our chronic suppressive doses. So again, it does change it at least to a BID regimen, or may even be utilized as a daily if we do the Valtrex as 1 gram, and I have some patients that will do that. And those are really patients who are having quite a few outbreaks. If they have 1 a year, I probably wouldn't subject them to suppressive therapy, but I do have some patients who have had more than 3 outbreaks in a year, and do take suppressive therapy for that. The other anal or genital warts, also known as condyloma acuminata, remember, caused by certain HPV strains, particularly 6 and 11, not necessarily the cancerous types of HPV like 16 and 18 that we're always screening for, whether that's through an anal pap or cervical pap. But some of these can become fairly large and sometimes do require surgical excision. This is just what they could look like. I should have warned everybody about some of my pictures. Here's another diagram. And then in terms of treatment, sometimes I think we talked a few sessions ago, I think maybe we had a case we had presented. Some cases can respond to the topicals, and usually we tend to use either the Condylox or Aldera treatments topically. We will sometimes use these when we do our anal screenings and may see a low grade or high grade dysplasia, and we will send them to the surgeon for endoscopy and 4-quadrant biopsies. Sometimes they will recommend using this treatment to see if we could get some regression of those areas. But in this situation, we're talking about treatment for actually just genital or anal warts, and then can sometimes require surgical excision. I've had several patients that their lesions were too large to really use the topicals and had to get surgical excision of those. The next twin that we're going to talk about is chancroid. And this is a little bit different than syphilis. Remember, syphilis is going to be a painful syphilis is going to be a painless lesion. Chancroid is a painful lesion. So remember, with syphilis, a lot of times people don't even know that they may have had primary syphilis with just the chancre or lesion, because it may have been small and it's really painless, and it may have gone unnoticed, and then they may present in secondary syphilis. With chancroid, they'll know that they have the lesion. It's very painful, and it's not always just one lesion. It can be multiple lesions as well. It has a base that's fairly erythematous. Sometimes can be associated with some purulent exudate with it. They can get lymph nodes that get inflamed associated with it as well. You'll see it after 4 to 10 days of incubation. Most of the time, we're doing a workup to look for the other sexually transmitted infections as well. And we're going to include syphilis testing, but if that is negative, it's more of a clinical diagnosis. Treatment has been, oftentimes, if you're treating gonorrhea and chlamydia, you're getting treatment for your chancroid too, but the treatment has been azithromycin or ceftriaxone 250 milligrams, one-time dose. And then there's an alternative treatment there with Cipro. So I've had maybe a couple of cases of this as well. I think the biggest thing to remember is that it is a painful ulcer or painful ulcerations. Oh, and that was my last slide. So I'm happy to take some questions at this time about